A pleasant day to all of you future RMTs. Once again, welcome to this virtual classroom. And in this lecture, what we are going to discuss is all about methods of evaluation. Our learning outcomes are as follows. Explain the importance of quality control program, including samples, determining control range, and quality control charts. Number two is to assess the diagnostic usefulness of results reported, which requires an understanding of accuracy and precision, as well as specificity and sensitivity. To start with, it is necessary to us to identify or to understand what is total quality management. When we say total quality management, that is a managerial process that is focused on the improvement of the quality of all factors affecting laboratory testing and performance. It is important for you to know and for you to remember that quality assessment or quality management in the laboratory is one of the most important factors to consider in maintaining the accuracy, reliability, and precision of our test results. Total Quality Management or TQM is a managerial process that aims to provide and aims to improve as well as aims to maintain the quality of management, the quality of results being rendered, the quality of procedures or services being rendered to our clients. However, if we are going to define quality, quality is something or somehow a vague or a broad concept because there is no exact definition of quality. If you are going to take a look the definition of quality on our references or in uh, a dictionary or other literatures, there will be a great difference between the definition of quality. Why? Because quality is something that is being perceived by the patient or by the client. The quality depends on how the patient or how the uh, customers perceived quality. No, quality varies among the patient. It is easy for us to take note and to identify and to say quality is our goal, quality results, quality service. But at the end of the day, the quality that we are aiming, the quality that we are saying, the quality that we are claiming should be defined and should be uh, what you call this should be perceived by our clients so that we can say that there is really quality in what we are doing. That is basically as simple as you did something, you satisfy your client, and you satisfy because of the quality that they are looking for a service that they want to have. Okay? So that is quality, total quality management. All aspects of the quality is being managed, for the improvement of the processes. Now, when we are going to discuss total quality management, there are five concepts that you have to remember under total quality management. What are those? The quality laboratory process, the quality control, the quality assessment, the quality improvement, and the quality planning. Okay? So let's discuss first the quality laboratory processes or process. When we said quality laboratory process, that is something to do with the processes within the laboratory. The procedures that you are going to perform, how are you going to perform the test? How will you result the test? How are you going to ensure that the test that you are doing, the results that you are giving, is really on the state of quality? And by doing the quality laboratory process, we can say, or by doing the total quality management, we can say that our laboratory processes are on the state of what we call quality. Let's say, for example, you are going to perform a test. Is the test that you are going to perform or the procedure that you are going to do, the procedure you did for that certain test, is really the procedure that is stipulated in the manual of operations? Is the manual of operations validated? Is the manual of operations is being reviewed in order to attain the laboratory processes is at the state of quality? Okay? In other words, when we said laboratory or quality laboratory process, we are ensuring and we are making sure that all tests, that all procedures are being done on the state of quality. And how can we say that we perform the test based or on the state of quality? We perform the test based on what is in our procedure. Next is quality control. For quality control, we're going to discuss it in further later. But to give you an idea, you are controlling, you are making sure that all the tests that you are doing is on the state of quality. Quality assessment is will be discussed also in the next slide. But when we said quality assessment, you are assessing the quality of the service that you are rendering. Quality improvement, or sometimes they call it as the CQI, or the continuous quality improvement. What does it mean? When we said quality improvement, you are maintaining, you are still improving, you are still aiming for a better, for improvement of your services. Let's say, for example, quality improvement includes the target. Let's say the target of the customer satisfaction measure for this or for the releasing of the results, or should we say the courtesy of medical technologists should be or is set or was set at 4.10. Based on the customer satisfaction measure, you achieve the 4.10. You got 4.11. Having said that you got a 4.11, it means that you achieve your goal. It means you are able to show that you are courteous to your patients. But part of the quality improvement or continuous quality improvement is how are you going to maintain that 4.11 satisfaction measure? How are you going to improve it further? How will you make it at least a score of 5? In quality improvement, no, you are not stop dreaming. You are not stop in improving. That's why, or thus, in the word itself, continuous. You are continuing the quality improvement that you should have in your laboratory. And lastly, or last part of the total quality management is what we call the quality planning. Quality planning is not a planning wherein you will just plan for a couple of minutes. Quality planning requires time, requires brainstorming, and the planning should be smart. When we said smart, it should be specific, measurable, attainable, realistic, and time bound. Those are the things that we have to consider in total quality management. Again, when we said total quality management, that is a managerial process or a management process that focuses on a improvement of the quality of all quality of the factors affecting laboratory testing and performance. Okay? Now, when we said quality assessment, it is a systematic laboratory program. If we are going to define systematic, it means in order. No? There is order in improving or in assessing our quality. And when we said quality assessment, it includes the pre-analytical, analytical, and post-analytical factors of the examination, or simply the pre-examination, the examination, and examination factors. As you can see in the illustration, one of the most important factors in quality assessment is the feedback of our customers. It is therefore necessary that each laboratory or each institution must provide a systematic way on how are we going to assess the state of our services. And one of those things is the customer satisfaction measure, or simply the feedback from our consumers, rather customers. Okay? By that, we'll be able to assess our processes. Okay? Quality assessment includes the following. We should assess the following: the specimen acceptability, the test methodologies, instruments, reagents, quality control, and personnel competency. Okay? Those are the things that we should remember when we are going to discuss or when we say quality assessment. Number one, let's discuss specimen acceptability. When we say specimen acceptability, how are we going to assess the quality of our specimen acceptability? Because there is no standard test and it is too difficult, no, to identify or to take note if we or if our registered medical technologists are really doing their best in accepting the samples that should be tested in the laboratory. Let's say, for example, a hemolyzed sample, or a slightly hemolyzed rather. A slightly hemolyzed sample was submitted in the laboratory for testing. In the laboratory in the laboratory operation manual or manual of operation, it is clearly stated that all serum samples should not be hemolyzed. However, no, however, since we cannot see all the times our registered medical technologists or our staff medical technologists, if they are really following that, then it is too hard for us to make a concept on how are we going to accept or how we are going to assess our specimen acceptability. If our staff medical technologists are really doing what is stipulated in our manual of operations. Okay? Because if you will ask the staff, have you followed or did you follow the procedure? Definitely they will say yes. Definitely they will say, yes, I do. Okay? That's why each laboratory should come up on how are we going to take note, on how are we going to assess our staff medical technologists in terms of specimen acceptability. Next is test methodologies. Is the procedure that you are doing is really acceptable? How are you going to assess it? What are the parameters that you are going to make sure or that you are going to do or parameters that you are going to use in order to make sure that the test methodologies are being performed in accuracy and precision? Instruments. We are also assessing our instrument, as instrument is a great factor or a great part of the examination variable. Reagents. Are our reagents acceptable? The same lot number? The same control? Did we control? Did we standardize our reagent, our machine? Okay. Quality control. Yes, you might be performing quality control every 12 midnight, but the question is, are you really ensuring the quality control of your laboratory? Did you assess it? Have you analyzed the results of your quality control? Or you just perform the quality control without doing something in order to take note if you really control your test. And most important thing is the personal competency. And if I will be a chief medical technologist, I will give an annual examination to my staff. What's the purpose of that? The purpose of that is to maintain or to take note if my staff are still competent in what they are doing. And that is a part of quality assessment. Yes, some says repetition will make you better, but sometimes those repetitions are just shortcuts of what we should do. And because we are doing shortcuts, we fail to perform what is necessary. Another example of personal competency is assigning the right person in performing the task that he or she must perform. Why will you assign a newly hired and newly passed licensed medical technologist to perform blood typing in blood banking if he or she doesn't have yet enough background on performing those things? Yes, he or she might be a registered medical technologist, but it is not an assurance that he or she is competent in doing the blood typing and blood cross matching. A medical technologist assigned in a specialized area must be competent enough in performing all the procedures that he or she will perform on that particular area. Why will you assign someone in histopathology section who even don't know how to operate microtome? At the end of the day, it will not give you a good section of your tissue. That's why it is important that a medical technologist should engage himself or herself in continuing professional education. But the problem is the cost of this CPE. Okay? Those are the parts or those are the things that we have to remember if we are going to discuss quality assessment. Now, we have here the examination variables, which includes the pre-examination, examination, or post-examination. However, we can call it as pre-analytical, or post-analytical. It doesn't matter if you will call it analytical, post-analytical, or pre-analytical. What is important for you to remember are the factors under each category. When we said pre-analytical examination, those are the things that falls before the analysis, which includes the specimen collection, the specimen transport, the patient identification, and so on. When we said examination, those are the things that part of the testing itself. No, this is the testing process already. The reagents, the instruments, the quality control, and calibration of our machine. And lastly, we have the performance of the registered medical technologist as a great factor in examination variable. Like what I said, no, repetition will make you perfect. Repetition will make you better. Repetition will make you understand what you are doing. But it should be, but you must ensure that the one that you are doing repeatedly is really the one that you should perform. Hindi yung you are skipping something, you're skipping the most important factors to do in performing a test. And lastly is the post-examination, which includes the clerical errors. That is one of the most common errors that includes in the post-examination, the clerical errors, no? Mismatch in the reporting of the results and the test interpretation. However, the test interpretation is more on the physician side. But I want you to take note that we are also interpreting the results before we release the results to the patient. In other words, before the doctor decides, you will decide na if you are going to release the result or not. That's why it is important as early as now for you to know how to decide and for you to exercise your decision making. We have here another concept such as accuracy and precision. Well, of course, I know this is not the first time that you have encountered accuracy and precision. But to have a review, how are we going to define accuracy and precision? When we said accuracy, that is the closeness of our assayed value to the true value. And when we said precision, that is the closeness of our assayed value to one another. And in order for us to really understand the concept of accuracy and precision, we have here three graphical representations of accuracy and precision. The first illustration shows a measured as accurate and precise. Accurate because all the test results are within the target value or within the true value. Precise because all of the test results are close to one another. Should we say that that is 1, 1.1, 1.2, or 1.1? Okay? The second illustration at the middle shows not accurate but precise. No? That's why it is what you call this? It is recommended or ideal to have an accurate, precise, and reliable results. Now, the second illustration shows not accurate. Not accurate because of the test or the assayed value are far away or far from our true value. But precise because the test results or the assayed value are close to one another. The third or last picture shows not accurate and at the same time not precise. Not accurate because no one from the test assay or assayed values are within the acceptable range or not within the target area and the results are away from each other. Okay, so that is the concept of accuracy and precision. Now, how about reliability? If accuracy is the closeness of the true value of the assayed value to the true value, and precision is the closeness of the assayed value to one another, now reliability is the ability to maintain accuracy and precision over the extended period of times. No? Hindi yung you only have the reliable results every time that you are going to perform quality control. You will have a reliable results only the time when there is a national external quality assurance scheme. No, it shouldn't be like that. Reliability should be maintained for all the times, for over the for extended period of times. No, from the very beginning until the last day of the operation of your laboratory, the results that you are going to release should be reliable because that is the only thing, one of the things that will help the physicians no, to think and decide no, on the management for their patients. Okay, so those that is reliability. Now, in this picture, we have not reliable, not valid. Reliable because they are precise, not valid because they are not within the true value. They are not accurate. No. Number two is not reliable, valid. Number three is neither reliable nor valid. And number four, they are both. It is both reliable and valid. the accuracy and precision is or was observed. Okay? Next in line is we have the quality control. When we said quality control, that is a way used to monitor analytical processes or detect or to prevent errors. Again, when we said quality control, it is used not to monitor analytical process to detect and prevent errors. And quality control is defined or discussed or what you call this categorized into two. We have internal quality control and external quality control. Okay, first is we're going to discuss internal quality control. When we said internal quality control, it is performed using control materials of known values and comparing the control values to establish acceptable range. From the word itself, internal quality control, we are performing the test, we are performing the control within our capacity. Okay? And the test or the controls that we are going to use are the controls coming from the manufacturer. Controls that are coming from the manufacturer of our machine. Okay? And we are going to have that, no, or compare that on the true values established by our manufacturer. Okay, and internal quality control is measured or assessed rather using the Levy-Jennings control chart and the Westgard rules. Okay, internal quality control is also a comprehensive program involving statistical analysis of control materials. Okay, and when you said control materials, that can be a lyophilized, I'm sorry, uh, yeah, lyophilized rather, I'm sorry, lyophilized or liquid material coming from our manufacturer. And take note, if that is a lyophilized sample, it must be reconstituted properly based on the principle or based on the procedure prescribed by the manufacturer. Sometimes this lyophilized serum comes with a diluent no or standard that will be used for reconstituting our lyophilized sample. Okay? And control material should be handled exactly the same way on how are we going to handle our patient sample. Okay? And usually control materials are two or in pair. One is within the reference interval and the other one is outside the reference interval. Why? What is the purpose of having one within the reference range and the other one is abnormal? Sometimes that is the positive control and the negative control. What is the purpose of that? In order for us to take note if our machine is sensitive enough, specific enough in detecting or analyzing the test results, the test or the analyte that we are going to test. Okay? And control material should be or is preferably the same lot number of the control. Okay? So, like we have said, our internal quality control is measured using the Leverage-Jennings chart and the Westgard rules or Westgard multi-rules. And when we said Leverage-Jennings chart, that is constructed monthly for each controls using the mean, positive, negative, 3SD. Okay, so as you can see here, we have here the mean or the average of our assay value. And from the mean, we are going to plot our test or our assay value, whether as if they are under the positive SD, positive 1 SD, positive 2 SD, positive 3 SD, positive 4, positive, yeah, 3 SD, negative 1 SD, negative 2 SD, negative 3 SD, and so on. No? Until negative 3 or positive 3 SD lang. Later in our Westgard rules, we are going to discuss these things. Ano yung mga rules na na-violate? in our Levigenin's chart. No? And as you can see, we have here, no? You can see here a UCL, it means the upper class limit, which is usually the positive SD or the positive 3SD, and the LCL, which is the lower SD or the lower class limit, or usually the negative 3SD. Okay? Remember guys that Levigenin's chart is a graphical representation of observed values of control materials over time. Okay? Later, I'm going to teach you on how we're going to do a Levigenin's chart. Okay? And when we set the Westgard rules, these are used to utilize control rules to assess numerical quality control data. Okay? Take note, this is a takeaway point number 1. Control values that exceeds the mean positive negative 2 SD or standard deviations are generally considered unacceptable and alert personnel to investigate the cause of a result that falls under positive negative 3 SD. Okay? Now, what is the difference between shift and trend? Okay? Shift is the gradual change in the mean that is reflected as either decrease or increase of consecutive values. This is usually or generally 6 or more times or 6 or more occurs in one direction. As you can see in this illustration, this is an example of shift, a sudden change, no, in our value or in the pattern of our graph. I'm sorry, that is trend pala. This is trend. I'm sorry. No, gradual change in the means that is reflected as decrease or increase. In this case, we can see that there is a gradual trend, no, increasing of our results, no, in our quality control. While shift is a sudden change in the mean that is reflected as consecutive controls above or below the mean. In this case, we have here a shift or sudden change, no, in our control or in our value. Kapag trend, gradual change. Kapag sudden change, that is shift. So, madali. SS, sudden shift. GT, gradual trend. Okay, and kapag trend, generally, 6 times po silang or 6 consecutive times yung value na nag-occur in one direction. Okay, again, takeaway number 2, a loss of precision is obvious on the chart when control values becomes more dispersed. What does it mean? Kapag mas kalat ang inyong laboratory chart or quality control chart, it means mas sabog po ang inyong control. Loss of precision in what you are doing. Okay? So for the Westgard rule, we have here the control rules established to limit the data rejection in a system with a 2 controls. Okay? We have here the 1 2S, 1 3S, 2 2S, R 4S, 4 1S, and X 10. Okay, so what do we mean by 1 2S? 1 2S is defined as control values that exceeds the positive negative 2SD. So in other words, there is one control that exceeds the positive or negative 2SD, which means our control value falls under the 3SD. And take note guys, it is necessary or it is acceptable, no, that our test results should only be or should only fall under the positive 2S or negative 2S. If these things happen, then that is a warning rule that triggers the inspection of the control values. How about 1,3S? 1,3S is a result that exceeds the positive or negative 3SD. No? Ito lang dapat, hanggang dito lang sa 2SD, pero yung result mo is away or exceeds the 3SD na. Okay? Usually, 1,3S detects a random error. Random error will be discussed later. Another here is the 2,2S, which is a two consecutive control values exceeds the same 2SD. Okay? So, kanina 1, 2S, one control value exceeds 1SD, 2SD. This time, we have two values that exceeds the 2SD. This one detects systematic error. How about the R4S? R4S control value or in a group exceeds the positive 2SD. The second control value exceeds the negative 2SD, creating a 4SD spread. Detects random error. 4,1S is a 4 consecutive values. Okay, control values are recorded one side of the mean and exceeds either the same mean 1SD or 2SD. 4,1S detects systematic error. And 10X is a 10 consecutive control values are recorded on one side of the mean. Okay? Usually, 10X detects systematic error. Okay? We also have here a Youden plot, which is a graphical technique for analyzing inter-laboratory data when each laboratory has made two runs on the same analyte or one run on a different analyte. Usually, Youden plot is seen in our machine. Okay? While for external quality control, that is analyzing specimens sent by external agency, or usually it is sometimes referred as the proficiency testing. Example of this one is what I have mentioned to you in the past, which is the National External Quality Assurance Scheme. Okay? And as per clinical chemistry section, our reference laboratory for clinical chemistry is the Lung Center of the Philippines. Okay? Again, when we said external quality control, it refers to a program where a clinical laboratory contacts with agency to receive the assay samples. In the case of the Philippines, for clinical chemistry section, the samples for external quality control is sent by our national reference laboratory, and in that case, that is the Lung Center of the Philippines. Siyempre, you have to what you call this, apply for this external quality control, no? And you are going to assess it, or you're going to run the test, no, the analyte that was given by the National Reference Laboratory, in order for you to know, that in order for us to know if we really have an accurate and precise results. Okay? Again, external quality control is sometimes referred or usually referred as the proficiency testing, and proficiency testing is defined as to determine the performance of the laboratory. Okay? Usually, proficiency testings or proficiency samples are sent by the National Reference Laboratory, and it should be treated as similar matrix of the patient. No, usually these are pooled samples. No, when I said pooled, pinagsama-samang serum samples or samples ng patient, no, na tinetest. They are generally lyophilized with diluent included to it and utilized for proficiency testing. Now, what are the limitations of external quality control? The limitations of it, number one, is, of course, since this is an external quality control and making sure that your test is valid, Some laboratories are treating the samples different from the normal samples. Kumbaga, in this world, merong special treatment. Okay? And since the results will only be reflected or will only be uploaded in our system, no, in the system of the lung center, hindi po nakikita dito yung pre-examination variables ng mga laboratory. Okay? This is the problem with the limitation of external quality control. The test, or this is just assessing the examination phase rather of the laboratory, not the pre-analytical, not the post-analytical. Okay, so that is the problem within the limitations of external and external quality control. So we have here error. Now this is another concept, and when you said error, that is the difference between the test and the reference method. And usually error is defined or categorized as random error and systematic error. A while ago in our Westgard rules, we said that this rule detects random error, this rule detects a systematic error. So when we said random error, it is present in all measurements. And random error affects the precision. Take note that there is no known pattern for random error. From the word itself, random, hindi mo alam when it will occur. Okay? In our Westgard rule, 1, 3S, and 4 and R4S detects our our random error. Okay? 1, 3S, and R4S detects our random error. Okay? Random error includes the instrument problem, operator, reagents, and environmental variations ng laboratory. Usually, ang pinakamaarting machine sa lahat ng machine in the clinical laboratory section is yung machine ng clinical chemistry. Siya po dapat ay nalalamigan, hindi naiinitan, at hindi po hinihinaan ang aircon sa clinical chemistry section. Okay? Now, how about systematic error? When we said systematic error, no, it means influences observation consistently in one direction, predictable, and cause constant difference in the results, unlike our random error. No, systematic error includes calibration, incorrect calibration, deteriorated reagents, and instrument malfunctions. Okay? The question is usually what is the most common cause of systematic error, and the answer is deteriorated reagents. Okay? Systematic error is furtherly classified into two. We have constant error and proportional error. When we said constant error, that is a continual difference between the test method and the comparative method, while proportional error is a difference between the test method and the comparative method values are proportional to the analyte concentration. Okay. Next concept is we have the reference range or reference ranges. This is determined by the laboratory to fit their particular population. That's why if you are going to compare the reference range of each laboratories, they varies. Iba-iba sila ng reference range. Why? Number one reason is because of the establishing the reference range that they have. Another two is the principle of the machine that they are using. And lastly is the validation of their reference range. That's why you cannot compare the reference range of each hospitals because they are not the same. No? And that is calculated based or for each laboratory's test menu. Okay? Now, how are we going to establish and verify our reference range? Please take note of this, guys. When we are establishing a reference range, again, when we are establishing a reference range, we must have at least 120 samples from individual patients from the same sex and the same age, no, to establish our reference range. And usually, the reference range will get, or we will get the mean of the reference range as well as the standard deviation, and the reference range for that one should be only limited for 2SD or positive, or to positive and negative 2SD. Okay, the reference range should only be fall for the positive S2 and negative 2 ST. Again, for establishing reference range or reference intervals that are just the same, you must have at least 120 samples to establish that. Nakikitandaan, 120 samples. Now, for uh, verifying the reference interval, we need only 20 samples to validate that. Okay? So again, for establishing reference interval, now we are going to calculate the mean as well as the SD, and positive negative 2 SD will be our reference range. Okay, positive 2 SD will be our upper class limit, and the negative 2 SD will be our lower class limit, or yung pinakamababang acceptable value. Okay, so how are we going to verify our reference intervals or reference range? Again, kailangan natin ng at least 20 samples or some specimen that will be subjected for performing the test. No, we are going to compare the results with existing 95% reference interval provided by our manufacturer or by the literature. Okay, so if they are 10% or less than 10% of the normal range, then use the reference method interval. If the result is 10% outside the range, now it means that we have to repeat the testing of the 20 samples. Now, if we repeat, if we repeat the testing of the 20 samples, and again, they are less than 10% of the range, then now use the reference interval. Once again, if we have greater than 10% outside the range, then we have to evaluate the donor's population, and possibly we have to use 120 samples. Okay? So this is the algorithm on how are we going to verify our reference intervals. Okay? For operating instructions, ito yung mga dapat nandoon sa ating manual of operations. Per test, we have the test name, the method principle, the significance of the test, the patient preparation, test specimen requirements, equipment and materials needed, reagent preparation, test procedure, calculations, quality control procedures, reference intervals, panic values, limitations of the procedures, and the references for checking. Okay? So the next video that we are going to have, or the next part, is about the statistical analysis. Okay? So I will upload a second part of this video for statistical analysis alone. Thank you and God bless you all.